I am Atakan Varol, founding director of Institute of Smart Systems and Artificial Intelligence. With young researchers of ISSAI, we have developed a COVID-19 simulator for Kazakhstan. COVID-19 epidemic has emerged as a global crisis that threatens to overwhelm public healthcare systems and disrupt the social and economic welfare of every country. The daily lives of billions are impacted by the unprecedented attempts of governments to control the spread through the imposition of strict quarantines and social distancing measures. COVID-19 has propagated rapidly amongst a globally susceptible population, with a high mortality rate amongst its victims, and the unfortunate characteristic that carriers are highly contagious in pre-symptomatic states. The situation is worsened by the fact that the population has no prior exposure and there is no vaccine yet available, and that widespread testing for the virus began quite late due to the lack of testing kits and facilities. In this scenario, epidemiological models can be used to project the future course of the disease and to estimate the impact of measures that might be used to control its spread. To help in this time of crisis, the SEIR team of Nazarbayev University has developed a stochastic epidemic simulator calibrated with real-world experience and customized for the Republic of Kazakhstan. The simulator uses real data, ranging from population density to healthcare capacity for each region, to predict the dynamics of the spread of COVID-19 in Kazakhstan and thereby inform government policy making. We model Kazakhstan as a graph of 17 connected nodes, 14 oblasts, and 3 cities of Republican significance, where each node runs a separate epidemiological model. Based on air, rail, and highway connections between the nodes, we also model the spread of the disease between different geographic regions. The simulator is initially configured to model the current situation and project the ongoing impact, which can be used to facilitate government allocation of resources. The real value of the simulator is that it enables the modeling of disease suppression and mitigation measures, such as limiting travel or quarantining a region on both a localized and national basis. The simulator can be used to estimate the impact and duration of the epidemic over time based on a range of policy measures and might allow better state planning to reduce the impact. We are sharing the source code such that it can be used, adapted, and improved by others. In order to model this epidemic, we are firstly incorporating the experience of China, the cruise ship Diamond Princess, and the epicenter of the epidemic in Europe or Italy, Lombardy. In China, where the epidemic has started, the overall reported mortality rate is 3.8%. Mortality rate is high for 70 plus, 8%, and even higher for 80 plus, 14.8%. When we look at the case of Diamond Princess, we have a different picture. The COVID-19 epidemic on the Diamond Princess cruise ship provides valuable information since it was a closed system conducive to disease transmission with lots of testing conducted on the passengers. 1/3 of the passengers of this ship was 70 plus. Out of 3,711 passengers, 619 got infected in 3 weeks, hinting rapid disease transmission. 7 deaths are reported out of 619 cases, resulting in a case mortality rate of 1.1%. According to the China COVID mortality rates, 35 deaths would have been expected in the Diamond Princess cruise ship. Definitely, the number of deaths is less than expected, which is very good. Let us combine the information from the Diamond Princess, which is a very closely observed experiment, with the population pyramids of Lombardy, the epicenter of the epidemic in Italy and Kazakhstan. Since mortality rate is higher for elderly and the average age in Diamond Princess was 57, the COVID-19 related mortality rate in Diamond Princess should have been on the higher end of the scale, using the age-related mortality ratios from the Chinese data. 1.1% case mortality rate of Diamond Princess, and population pyramids of respective countries and cases we expect the mortality rates of Lombardy and Kazakhstan to be 0.7% and 0.3%. Lombardy mortality rate is more than double Kazakhstan's expected rate because Kazakhstan has much fewer persons with age 80 plus and significantly less number of persons aged 70 plus. As of now, we have been making assumptions based on the mortality rate of a cruise ship. This might not be extremely solid. How can we test our assumptions on the mortality rate? Firstly, we can do large-scale testing. A large portion of the population can be tested randomly for COVID-19. This would provide reliable estimates on the number of infected with COVID-19, and based on the number of deaths, the mortality rate can be computed. This is not very practical because as of now, we don't have the ability to test very big chunks of the population. Another option is doing large-scale serological testing. Serological tests look for antibodies in blood. They can identify people who were infected and recovered from COVID-19. Combined with random sampling, the full scope of the epidemic in a region or country can be estimated. As of now, there is no approved serological tests for COVID-19. In order to test our assumptions, we will first focus on the simulation of the Lombardy region in Italy. Lombardy is the epicenter of COVID-19, so it started most probably there at an early date. Its population is around 10 million in a very densely populated fashion. There are already over 6,000 COVID-19 related deaths, and the epidemic timeline is quite well established. In addition to this, Italian government shares its data daily since 24 February 2020. The data from Lombardy can be downloaded from the GitHub site of the Italian government, and it just gives the hospitalized numbers with symptoms, intensive care cases, total number of hospitalized, home isolation cases, total number of current cases, new cases for that day, the number of recovered people, the number of dead, total number of cases, and the tests conducted for a given date. Cumulative number of tests. When we look to the Lombardy data, we realize that only 1% of the population is tested, and among those, 40% get tested positive for COVID-19. 100,000 might appear like a very high number, but that is only 1% out of 10 million population. 6,000 deaths occurred so far. That's a quite big number. And with the latest daily number of 542 deaths as of 28 March 2020. In the initial days, for every hospitalized person, 1/4 of them were going to the intensive care, but right now we are observing that a much smaller percentage of the hospitalized cases are going to the intensive care. This might suggest the saturation of intensive care unit capacity and possibly might account for the higher mortality rate compared to the Diamond Princess. The public healthcare system of Lombardy might be overstretched right now. And in addition to that, 28% of the positive tested cases are hospitalized as of now. Now, let's reconnect Lombardy and Diamond Princess. Lombardy already has 6,000 deaths. If the mortality rate is 0.7% as predicted, there should be 850,000 infected in Lombardy. Considering that the number of confirmed cases in the whole world as of 29 March 2020 is 677,000, 850,000 appears to be extreme. Presumably, the mortality rate in Lombardy might be higher than 0.7% because ICUs are overloaded and cannot serve new patients. However, even if we account for the increased mortality rate due to the saturated ICUs, there should be around 500,000 infected in Lombardy. This suggests that mild or asymptomatic cases of COVID-19 are heavily underreported. Good. COVID-19 is not as deadly as predicted by the earlier research. But there are much more infected people around. It is very hard to contain this epidemic. Ugly, we don't have enough random tests or any serological tests to verify these claims. What should we do? We can look at history to the previous cases of pandemics and epidemics, or we can simulate Lombardy and find a model that fits. Past is usually a good predictor of the future. Therefore, let us look to the 2009 H1N1 influenza epidemic in the United States. After a 3-year analysis, Center for Disease Control predicted 59 million cases for swine flu, 265,000 hospitalizations, and 12,000 deaths. The case mortality rate was 0.02%. Our mathematical analysis predicted the mortality rate for COVID-19 as 0.7% for Lombardy, 35 times H1N1 rates, and 0.3% for Kazakhstan, 15 times the H1N1 rate. But I would like to point out that 59 million people, approximately 20% of the population of the United States, was infected during the H1N1 influenza epidemic. Maybe it might be true that the number of infected for COVID-19 is also very high. Let us have a close look to the Lombardy COVID-19 timeline. On 21 January 2020, a COVID-19 infected person comes from China. This person transmits the disease to a male person, and the male person goes to a doctor, and on 14 February 2020, and he and his wife were later confirmed positive for COVID-19. On 20 February 2020, there were already 3 other confirmed cases in Lombardy. On 24 February, there are already 6 deaths, 172 confirmed cases, and COVID-19 was, according to our estimates, spreading for 36 days in the community. The first intervention from the state comes on 2nd March 2020, red zone in Lombardy. Then 6 days after that, when the number of dead reaches 267, whole Lombardy locked down. And then afterwards, every week with the increasing death numbers, more and more interventions by the state. Now, we need a model to simulate Lombardy region, because our initial estimates of 0.77% mortality rate estimated for Lombardy or Italy would have pointed out that when there were 6 deaths, there were already 857 cases of COVID-19 in Lombardy. If we create this model and if we predict the current recorded deaths accurately, we might either have a good model, or we might simply be overfitting our model to the available data by utilizing the many parameters of our model. However, if our model shows good predictive accuracy for the next 1 week or so, then we can state that we have a good model and our assumptions were possibly solid. We will simulate Lombardy using a stochastic SEIR model. The work is based on a previous paper of mine which was presented in 2016. We have 4 superstates: susceptible, exposed, infected, and immunized. The simulation starts with the whole population in the susceptible state and a number of exposed individuals. In the susceptible state, we can transition to the vaccination and finally to the vaccination immunization. We are very well aware that there is no vaccination for COVID-19 yet, but we are optimistic, and therefore we just included this module and we reserved it for future implementations. However, currently, since there is no vaccination, we have the transition from susceptible to the exposed state. In the exposed state, the individuals spend around 5 days. They might be quarantined each day with a probability, and in their quarantined state, their probability of transmitting the disease to others is less. But from both of these exposed and quarantined states, they just transition to the infected. In infected state, they spend 14 days. On these 14 days, they might transition to the severe infected or hospitalized state, in which they just have a probability of death. The probability for death is higher if the hospital capacity is reached. From both infected and severe infected states, the individuals with a probability can transition to the recovery immunized. As of now, we assume that 90% of the people who don't die transition to the recovery immunized state, but we don't know what the real parameter for recovery immunization is. Some persons also might transition back to the susceptible, and that way can be sick with the COVID-19 disease multiple times. However, as of now, it is too early to state whether recovery immunization is happening, how many percent of the individuals might go back to the susceptible state, etc. If we have a high portion of the society in the immunized state, either through a vaccination which will be invented, discovered in the future, or either through recovery immunization, then we will have the herd immunity for the society. But in general, this whole simulation is running as a cycle over and over for a long duration, and this will be also used for the node simulation in our network-based Kazakhstan model. Using the epidemic model in the previous slide and tweaking its parameters and taking into account the measures taken by the state, we created the simulation for Lombardy. We have seen that we can closely match the real data with the simulated data, and it suggests that our model might have good predictive accuracy. As it can be observed from this model, in Lombardy we expect around 15,000 deaths, and the number of deaths per day will be less than 10 after 22nd of May. So there are around 52 more days for this epidemic to be over for Lombardy. As it might be observed, there are significantly high number of infected cases than the severe infected cases, and we also observed that the hospital capacity in Lombardy was reached, and right now the mortality rate is also higher because of that. During epidemics, measures are usually taken for specific administrative regions. For example, restricting movement within or between regions. These regions are connected via air, railway, and highway networks. Epidemics start usually in hubs with the import of the disease from another country and propagates to other regions via transportation between regions. Statistical data on the population, hospital capacity, and transportation connections of each region is usually available. Therefore, a country can be modeled using a graph consisting of a set of connected nodes. Kazakhstan is administratively divided into 17 regions, 14 oblasts, and 3 big cities, Almaty, Nur-Sultan, and Shymkent. Therefore, we modeled Kazakhstan a network with the regions as the nodes and the air, rail, and highway connections as the edges. Epidemics will most likely start in a hub and start moving to other regions via these transportation networks. In the case of Kazakhstan, most likely these hubs will be Nur-Sultan and Almaty cities. Here is the air transport network of Kazakhstan. As you can see, air transport network is extremely dense. There are connections more or less between many nodes in the graph, but you might also observe that Almaty and Nur-Sultan cities are the fundamental hubs of the country. The highway network is more sparse because the cities need to be connected using roads. And railway network is similar to the highway network of Kazakhstan as well. We collected data from open sources on the daily air, rail, and motorway travel between different regions of Kazakhstan. We combined this information in a daily transition matrix. In our simulation, we randomly sampled the population of a node for each transfer. For instance, there are 1,042 persons traveling from Almaty to Nur-Sultan daily. Almaty has a population of around 2 million. Assuming there are 15,000 infected persons in Almaty, there would be around 8 infected persons transferred from Almaty to Nur-Sultan daily. Of course, this is just an example. We don't know the exact numbers of infected people. The diagonal of this transition matrix is 0 because there is no transfer from a city to the city itself. But we also highlighted the Nur-Sultan and Almaty cities in this transition matrix to highlight the high numbers in these two cities. Let's have a look at the COVID-19 timeline of Kazakhstan. The first two cases were confirmed on 13th March 2020. Russia and Kyrgyzstan put restriction on free border crossings. The classes were converted to online classes and country-wide events were postponed. So this is a case when the Kazakhstan was already taking some measures even with the two confirmed cases in the country. On 16th of March, then there was 3 confirmed cases. The large gatherings in the country were restricted. On 19th March, national emergency state was announced and Almaty and Nur-Sultan cities were closed. The working hours of restaurants were restricted and penalties for quarantine violation were set. On 22nd March, Almaty and Nur-Sultan cities were cut off from the rest of the country. On 26th March, the first death was reported and restrictions of movement in Shymkent was enacted. And in Nur-Sultan and Almaty, going outside was prohibited except for essentials, going to critical work or going to a supermarket. On 30th March 2020, when there were 293 confirmed cases, Aktöbe, Kostanay, Atrao, Turkestan, and Karaganda regions were closed. Assuming average duration of 19 days for the disease, 5 days of incubation, and 14 days of infection. The first person who passed away should have contracted it around 7 March 2020. The first deaths in Lombardy were reported 33 days later than the import of COVID-19 from China. Even though Almaty and Nur-Sultan are locked down since 22 March 2020, there are COVID-19 cases in other regions which cannot be traced back to the confirmed cases right now. Combining the information 1, 2, and 3, we will assume in our simulations that there were 10 exposed persons in both Almaty and Nur-Sultan cities on 1 March 2020. Let us compare Lombardy and Kazakhstan. Predicted arrival of COVID-19 to Lombardy is 21 January 2020. First serious measure was taken on 2nd March 2020. Delay between the first case and the response is 39 days. Our predicted date of COVID-19 arrival to Kazakhstan is 1 March 2020. First serious measure by the state was taken on 13 March 2020. Delay between the first case and the response is 12 days. Kazakhstan was aware of the danger due to the extent of the epidemic in other countries and was quick to make interventions to prevent the spread of COVID-19. So therefore, we have been very lucky that this disease came to Kazakhstan late.